Started the timer, and here is your question. Yes, please. Yes, if you have read and understood, considering it surgical pathology station, what are your differentials?
I'm considering the young age and the colonoscopy requiring revealing multiple polyps. I would be thinking about FAP, familial adenomatous polyposis.
Okay. Why?
Usually there is, I mean, it's a condition where there is it's an autosomal dominant condition characterized by the loss
Yes.
of tumor suppressor gene, following which the patient has multiple adenomas all over throughout the colon, with a high chance of malignancy by the age of 40. And there is also a previous, I mean, her father has also passed away due to cancer. So,
So can you please tell me what are the genes involved in FAP?
APC gene,
Familial, yes, yes,
tumor suppressor gene mutation in APC gene
and
along the long arm of chromosome 5.
there are two more.
Um,
This is susceptible to what? Can you please tell me?
to formation of malignancy, ma'am.
Yes. So if it will cause malignancy, what are the genes which are responsible?
Ma'am, so there'll be loss of P53 and KRAS mutation. No.
Yeah, that was with the involvement of FAP, but now with the involvement of malignancy, so they are oncogenes, stability genes, TSG. So can you
I'm not
tell
sure about
me
the answer, ma'am.
how many types of adenoma are you aware of?
Um, the classification of polyps, ma'am.
Yeah, adenoma.
So
Polyps are of
it can be
different
either
types.
they can be divided into non-neoplastic, inflammatory and neoplastic, and the non-neoplastic can be hematomatous polyps or juvenile polyps or Peutz syndrome or any metaplastic polyps, whereas inflammatory could be pseudopolyps or ulcerative colitis, and neoplastic polyps can be classified as villus adenoma, tubular villus adenoma, and tubular adenoma.
What are
They
you
have more
looking at?
malignant potential.
Can you please describe the image?
It's a colonoscopy image showing multiple polyps all throughout the colon.
Okay. Can you please tell me how would you tell me that extracolonic FAP exists?
Uh, Ma'am, I would look. Uh,
Okay,
I'm sorry, ma'am. I'll come
all
back to this
right.
question.
Okay, can you please tell me what is the highest chances of malignancy occurring in the different types of polyps? So in which one it's more likely to for malignancy to
Most
occur?
propensity for malignancy, we would describe based on the degree of dysplasia. There's also classification based on the size of the adenoma. If it's less than 1 centimeter, there's around 5% chance. More than 2 centimeters, around 20% chance of malignancy, and the
Yes,
type of
and so
adenoma.
was Willis type of adenoma.
Villus is the most
Yes.
highest neoplastic potential, about 40,
Can you,
40%.
yes, if you are asked to describe the carcinoma sequence in adenoma, how would you explain?
Ma'am, so first basically,
Stepwise.
yes, so there's normal epithelium. Following the first hit would be the mutation in the APC gene,
Yes.
which will cause an initial dysplasia, followed by a second hit will be APC beta catenin gene, which will again cause a second hit, which will cause the formation of early adenoma.
Or
Following this,
dysplasia.
there will be mutation. Following this, there will be a mutation of KRAS, which will cause the dysplasia to develop from early adenoma to late stage adenoma. Following the mutation of P53 gene, there is a development of malignancy.
Okay, so can you please tell me how proto-oncogenes and tumor suppressor genes act?
So proto-oncogenes are basically the malignant variants of the normal. Proto-oncogenes are normal genes which are seen within the cell. The mutated versions are called as oncogenes, which is created by the
Yes.
mutations in the proto-oncogenes, which encodes for proteins which are called oncoproteins, which leads to undivided division of the cell without control. And tumor
Okay.
suppressor genes are gatekeeper genes, which tries to prevent over mutation of, over uh, replication
They
of the cells
innovate.
as well.
Yes. Yes. Please, can you tell me how would you classify the extent of carcinoma in the colon?
Ma'am, so there is two classifications which are
Yes.
followed mainly. There is Duke's classification, and then there can
Yes.
be TNM classification.
Yes.
Duke classification is mainly four stages. One is A, in which the tumor is confined towards the mucosa. Then B, which is again divided into B1 and B2. B1 is when the tumor is confirmed to the muscularis propria but not extending the serosa, and B2 is when it is extending beyond the muscularis propria and the serosa, but there's no lymph node involvement. Then Duke C is when there is lymph node involvement without involvement of serosa, that is less than three lymph nodes. Sorry, 1 to 4 lymph nodes. When there is a and C2 is when there is involvement of serosa along with more than 4 lymph nodes, and D is for distant metastasis. Another
Okay.
classification is a TNM classification, whereas again
Yes.
TIS is tumor in situ, T1 is tumor in submucosa, T2 is in the muscularis propria, and T3 would be in the muscularis.
In the
T3 would be
serosa.
muscularis propria and serosa, and T4 would be invading of the surface visceral peritoneum, and T4B would be invading of the adjacent structures. And
Good.
again, nodes are divided into N1A. That is one regional lymph node, and N1B is 2 to 3 regional lymph
Different.
nodes, and
Yeah.
NC is made up of multiple lymph nodes. And
Him.
metastasis again, M0 and M1.
Okay. Good. Uh, can you please tell me what management can you offer to this patient with FAP?
With FAP, we in view of the early chance of malignancy, we have to offer the patient prophylactic near total colectomy by the age of 25
Okay. Can
with
you? Yes.
diagnostic.
If you look at this image and according to this image, if you tell me both according to Duke and TNM staging, which stage is this?
Um, Ma'am, this will be there'll be involvement of mucosa and submucosa, and but I'm not sure about that answer. I'm gonna come back to that.
Okay. What lifestyle changes can you advise to the patient which can help in reducing the risk of colon cancer?
Right. For individuals who want to prevent the risk of colon cancer, we have to advise a fiber-rich diet to stay abstinence from
Yes.
or less amount of red meat in their diet, and limited intake of alcohol, or stop alcohol, and reduced fat intake, and to stop smoking as well. High
Okay.
fiber diet.
Can you define dysplasia, please?
Dysplasia is there is it's a development of characterized by increased mitosis and pleomorphism without the ability to invasion. So it's a transformation of one epithelium into a pre-malignant state.
Okay. What is the normal function of APC gene?
It is a tumor suppressor gene. It's a
And
gatekeeper gene which prevents the mutation of the
by
cell.
controlling what?
Regulates. It's a negative suppression by controlling the WNT pathway in clonic epithelium by promoting formation of complexes that degrade beta catenin.
Yes. Yes. Good. Okay, if you are asked to define an ulcer, what would be your answer?
Ulcer would be a break in continuity of the mucosa and epithelium.
Okay, if ulcer heals by secondary intention, then what would you understand by this term?
In secondary intention healing, there is a loss of tissue. So basically, the wound will heal with the help of reepithelialization and wound contraction, leading on to scarring.
Okay, good. Thank you so much.
The answer to the question, ma'am, in the picture, how can you determine the TNN and the
I asked according to both. Dr. Mohammed raised his hand. Can you tell?
Yeah.
Dr. Mohammed? Dr. Mohammed Ilian? Has he got disconnected? I think he got disconnected. Dr. Abhishek, would you want to tell? Who's writing?
He's writing that we can't see through this picture. But I'm not sure about that as well because we can't see the lymph node
No,
status
but
or
then
TNN.
this will be asked by looking at it. Okay, they are the
Hello.
polyps are yes,
Good
please.
evening.
Good evening.
Good evening. I don't know. Which picture are you?
This
Is
one
it the?
in front of you.
No, no. The question will not be asked regarding this picture. So they will give you another
Okay.
picture that shows the invasion of the tumor.
This is
Okay.
also showing invasion, but not okay. It's
No,
not
no,
the
no,
same
no,
one.
no.
No, ma'am.
The question is not to this picture. This can just be maybe for the question because although even though the station that former picture did, but
Yes.
for the TNS staging, they gave another picture that shows the tumor probably invaded the muscular layer and asked you to classify either like according to anyone the candidate chooses, either the Duke or the tennis staging.
Right.
Yes. Good.
So it is people with this picture.
It's not with this picture. Good.
Yeah.
Yeah.
In this picture, I mean, even in the traditional notes, they've written multiple polyps
Yes.
with the ulcerations, but I couldn't appreciate any ulceration in this as well, so I
No,
didn't say
in this
anything.
one, there is no ulceration. I can't see at least.
Yeah, even I can't make out.
But and then this one, I wasn't sure if they show this picture or another. If Dr. Sunday says not with this picture, then okay. Otherwise, they do show a picture and they do ask you to evaluate, assess
Right now.
according to both classifications. Started the timer, and here is your question. Right. So if you have read and understood, kindly please tell me what is the pathogenesis of this
Yeah,
patient's
yes,
condition?
there's no history. There's no history of trauma. I is most probably have a pathological fracture.
Yes, very good. Can you tell me the pathogenesis of pathological fractures? How do
Pathological
they take
fracture
place?
is a weakness of the bone itself. Is secondary to
Yes.
Any pathology.
What type of pathologies can lead to
It,
these sort
it
of
could be
fractures?
benign, like bone
Yes.
cyst. It could be inflammatory, like osteomyelitis, or metabolic, like a
Yes.
Paget disease, or malignant, like primary bone tumor, like multiple myeloma,
Yes.
osteosarcoma, or others.
Yes. So, according to this patient's history, what might be the condition that has led to fracture with mild traction?
Yeah, this is maybe cyst, bone cyst.
Considering the age of the patient?
Yes, young age.
Yes. So can you please tell me what management can you offer to the patient?
A patient should be firstly evaluation the cause, underlying the cause, take biopsy, and
Yes.
fixation of the fracture after consult the orthopedic surgeon.
Yes.
Yeah.
And then?
And treated accordingly. If he has a malignant cancer, secondary to the can decided is remove the tumor, chemotherapy, fixation, or benign, just curate and fixation the fracture.
What might be the, okay, you have told me what might be the causes of pathological fracture.
Yeah. It's,
Okay, can you please
benign
name,
or
yes or non?
Yeah.
They can be neoplastic or non-neoplastic.
Yeah.
If you classify it like that, then what are the non-neoplastic types?
neoplastic is benign bone lesion like bone cyst. It could be secondary to inflammatory like stomatitis
Osteomyelitis or Paget's disease, or bone cyst that
Paget
you are
disease.
telling that is not malignant. Bone cyst is non-malignant. That's
Benign
why
is
I'm,
benign.
yes, and osteoporosis. So can you name few possible sites where primary bone tumor can metastasize?
Yes, is the lung, thyroid, in the female breast,
Yes,
kidney,
yes,
and in the male is prostate.
yes. Good. Okay, can you please tell me if this patient's fracture was fixed, then how would you check for malignancy? How would you confirm?
By biopsy.
Good. Okay, if the pathology report you have done and it shows typical blood appearance with the follicular cells, then what would you think? What might be the primary site?
The thyroid gland.
Okay. So what are the other sites of ectopic thyroid tissues other than the head and neck of the thorax?
It could be ovary or testis, teratoma.
Okay, good. So if you have done FNAC of the thyroid but was unable to differentiate the carcinoma, what might be the reason?
Because the carcinoma is invade for basement membrane and fine needle aspiration only show the cell functional and pathology.
Okay. So what investigations would you do to confirm thyroid metastasis?
Biopsy. Biopsy.
Uh, radioactive iodine scan.
Yes, and radioactive image.
Which thyroid cancer will show no response to iodine uptake?
Medullary thyroid cancer.
Yes. What does medullary thyroid cancer has it different from where it takes
Is
origin?
malignant thyroid origin, malignant thyroid cancer originated from the parafollicular C cell.
Yes, not from the follicular C cells. That's why. So if a patient is O positive blood group, what test would you do prior to the blood transfusion?
APO and rhesus.
Okay. And if the patient is telling you patient's blood group, so you will still do cross matching.
Yes, we should do cross matching with
Why?
every time. Yes.
Okay.
But
As it is,
because there is
yes.
maybe developed antibody against recipient antigen.
Can you define hemolysis?
Hemolysis is destruction of the blood secondary to autoimmune reaction. Or,
Okay. What complications can result as a result of or what complications can occur as a result of blood transfusion, which is not cross
is
matched?
is hemolytic or non-hemolytic?
Yes.
Hemolytic is acute hemolytic reaction or delayed hemolytic reaction, or febrile non-hemolytic reaction, or acute lung injury. Non-hemolytic is hyperkalemia, hypocalcemia, and hypoxalemia, overload, DIC, hypothermia.
Okay. In the normal bone, what are the stages of bone healing?
First stage is inflammation, hematoma and inflammation, and this take days to week. And the second stage is fibrocartilaginous. This take 2 to 3 weeks, and this is characterized by new angiogenesis, fibroblast, osteoblast is recruitment for the site of the fracture. So, third stage is cartilaginous or hard callus. Last stage is remodeling.
Good. What management one can offer if patient's fixation is not healing or not uniting
If
and
the
turns
patient,
out to be, yes,
if the
because
fracture
this,
not healing,
yes, or not uniting.
first of all, we should sure the patient is good to take good nutrition. There is a good blood supply. There is no any foreign body inside, and patient maybe need for bone graft, autogenous or exogenous, and
Okay. What
yeah.
is the procedure for offering a patient bone graft? Would you do tissue matching?
No, because if we take a bone graft from the patient itself, we don't know, we don't need to.
What are the common sites of from where bones can be taken for grafting?
Iliac bone,
Okay. Any other?
sternum, iliac from cancellous bone,
Okay.
from metaphyseal of the long bone.
Sometimes they use fibula as well.
Yeah,
Depending. Yes. Good. Thank you.
thank you.
This does not belong to the patient, but if you can just help me read what you see in the X-ray.
This X-ray for ankle joint and distal tibia and fibula show the osteolytic lesion in the distal tibia, well defined, and um, yes, well defined. There is most probably it's common benign
Yes.
lesion. Yeah, before I go to diagnose, I need to see lateral X-ray.
Good. I didn't get the lateral one. I don't know why. Okay. Good. All right. Starting the timer, and here is your question. Yes. If you have read and understood the question, kindly tell me what is your provisional diagnosis.
As the patient is old age with occupational exposure to shipyard and
Yes.
industry and weight loss and anorexia, history of anorexia and weight loss of significant weight loss of 25 pounds, I think he is suffering from some lung carcinoma. And due to this chest X-ray final flora based, it is most likely a mesothelioma.
Very good. Can you please tell me the pathogenesis of the condition?
Of mesothelioma, it is
Yes.
due to
chronic exposure to asbestos.
Yes.
It leads to chronic inflammation, formation of pleural plaques, and dense collagen deposition.
Okay.
Which lead to increased risk of malignancy and mesothelioma and lung adenocarcinoma.
How the diagnosis should be made? Have they done enough if they've done chest X-ray?
No, it needs to be confirmed by biopsy
Yes.
and with the pleural tab.
Okay. What management can we offer to this patient? What
After,
management? Yes.
as it's a non-small cell carcinoma, he will be needing the chemotherapy.
Yes.
And initially, we will do staging of this patient,
Yes.
and after that, he will go most likely with palliative chemotherapy and radiotherapy.
Okay. How would you stage the patient? Is there any classification?
Classification will divide these patients into non-small cell lung cancers and the small cell lung cancers. Non-small cell lung cancers are further divided into adenocarcinomas, squamous cell carcinomas, and while the cell lung cancers are the tumors with neuroendocrine differentiation.
Okay.
And
Can you, okay. If the patient presented with metastasis and they were poorly differentiated, how would you tell if the cells were epithelial in origin?
for that, we have to take biopsy and immunohistochemistry of the
Yes.
cells to check
Good.
its origin and from where it is originating.
Good. So if the tumor was epidermal growth factor positive, what will be the chemotherapeutic agent?
In that case, we can give him tyrosine kinase inhibitors,
Good.
which are imatinib, sunitinib, and other tyrosine inhibitors.
If patient develops cough, what bedside test one can do?
We have to do his sputum analysis and other like pulmonary function tests and spirometry.
Okay. Can you tell me what you understand by the term pleural plaques?
Pleural plaques are the plaques of collagen deposition
Yes.
which occurs around the periphery of the lungs,
Yes.
and they occur due to chronic inflammation and due to exposure to carcinogenic agents,
So
and they
what
are
is
often
the
present.
yes? So what is the significance of finding pleural plaques?
They lead to increased risk of mesotheliomas
Malignancy.
and adenocarcinomas.
Yes, increased malignancy risk of mesothelioma and lung adenocarcinoma. Okay, if you can tell me what, okay, what are the risk factors for this patient? If you can tell me.
Risk factors are his male gender,
Yes.
old age, smoking history,
Yes.
and occupational exposure to industrial carcinogens and to dye and other and asbestos exposure and due
Yes.
to
Okay. So can you suggest some lifestyle changes which can help this patient?
first of all he should be advised to give up smoking
Yes.
and occupational he is
Occupational is
already
late because he's
not
already,
he is
yeah.
already retired. Yes, only we can give him
And gender is
stop
also,
smoking.
yes, non-modifiable. And anything
Yes.
else?
and we give him maintain his good nutrition,
Yes.
and otherwise chemotherapy and radio, according to the MDT discussion and
Yes.
whatever is decided in that meeting.
Good. Very good. Okay. Now my questions have ended, and I'm looking for more because you've answered all the questions very perfectly, and I'm short of questions now. Anyone else want to add any question? Can you tell me if there is any age group in particular which is susceptible to mesothelioma?
Mesothelioma is after 50s.
Okay, if you don't
Old age.
manage this patient, what are the complications that can occur?
Patient will develop the disease will progress and it will lead to pleural effusion and respiratory distress and respiratory failure.
Okay, how would you differentiate mesothelioma from a bronchogenic carcinoma?
Bronchogenic carcinoma is centrally located, mesothelioma is peripherally located, and bronchogenic carcinoma is, I think, slow growing, and mesothelioma has,
Diffuse
I'm sorry,
malignancy. It has diffuse malignancy.
yes, yes,
Separating between healthy and cancerous tissue is very bluey. So that's why it's difficult to treat mesothelioma.
yes,
So if there is any difference in the pleural effusion of bronchogenic carcinoma and mesothelioma,
difference in the pleural effusions.
yes,
Hmm,
or if you do the
sorry, ma'am, I don't know
okay,
about this.
that's all right. Bell is gone as well.
I'll, I'll check this out. Definitely, it's a good question.
Because otherwise it's hard to differentiate between them. Mesothelioma is hard to differentiate, like it's diffuse. So as compared to the other one.
Okay, ma'am. Okay, ma'am, thank you.
Thank you. Thank you so much. Anyone else want to add? I just in the middle got short of the questions. I thought, okay, yes, I didn't know. Can you please look at this slide and tell me the arrow is pointing at something, and can you please read slide A, B, and C?
Sorry.
No,
No, I'm sorry, I have no idea,
you
ma'am,
don't
about
even know
this.
which dye they have used. Okay, I'll send you the link this article and you can read. Okay, here, can you read this X-ray, please?
Yes, this is a chest X-ray posterior anterior view in
Yes,
which the trachea is central,
yes,
and however uh, there is air fluid level on left side, which is about half, which is uh, there is air fluid level opacity. There is air fluid level on the right side of chest, and however,
about the angles. What more can you see? There is A,
yes,
B, C,
and
D. According
yes,
to the like, if you can read A, B, C, D,
yes,
X-ray, then
trachea is central and
yes,
left-sided lung is fully expanded, while on right side the lung is not expanded and it is compressed, and cardiac shadow is seems to be enlarged. Diaphragm is not visible on the right side, and there is obliteration of the
yes,
cardiophrenic and costophrenic angles on the right
yes,
side, but
yes,
these are visible on the left side,
yes,
and there is
What more? What more? Is there anything else?
yes, there is increased opacity, higher opacities,
Good.
and however, there are increased higher opacities on the right side, and
Yes.
there is no foreign body visible,
No.
and
Yeah.
gastric shadow is present.
Yeah. Good. Thank you. That was
Thank
good.
you.